The Formthotics medical system is a patient-centric process of assessment utilizing clinician expertise to quickly and effectively select, fit, and adjust Formthotics. It is a comprehensive clinical method to improve lower limb function with custom-fitted Formthotics. It includes the 6 tests, objective clinical tests, and the 6 steps to select, fit, and adjust Formthotics custom medical orthotics. Foot morphology and motion test. Assessing foot morphology in the open kinetic chain provides a foundation for building the clinical information about a patient. It is the first piece of the clinical analysis jigsaw puzzle. The patient lies prone and the posterior aspect of the calcaneus is positioned in the frontal plane. You may need to externally rotate and flex the opposite knee or place a rolled towel under the opposite anterior hip to ensure the limb is in the frontal plane position. First, assess the subtalar joint. It should have 2/3 inversion and 1/3 eversion. Next, assess the metatarsal joint ranges in inversion, eversion, dorsiflexion, plantar flexion, abduction, and adduction are checked. Note excessive range, hypermobility, as well as any limitation or asymmetry between feet. Assess the first ray. Check for symmetrical dorsiflexion and plantar flexion of the first metatarsal in relation to the second metatarsal head position. Note limitation, hypermobility, and asymmetry. For the first MTPJ, the hallux needs to be able to dorsiflex approximately 65 degrees for normal walking gait. Note limitation and range clinically available. Apply a pronatory or dorsiflexion force to the 4th and 5th metatarsal heads to facilitate a locking effect at the metatarsal joint. This is the approximated subtalar joint, neutral. When the foot is stabilized in this way, assess the morphology. What is the position of the rear foot posterior vertical bisection to the leg posterior vertical bisection? Varus, parallel, or valgus? What is the position of the forefoot plantar plane in relation to the rear foot plantar plane? Varus, parallel, or valgus? What is the position of the first metatarsal head, first ray, in relationship to the second metatarsal head, second ray? Dorsiflexed, neutral, or plantar flexed? Is there a forefoot equinus? If the forefoot position is varus in relation to the plantar calcaneus, but there is good or excessive metatarsal joint range available, we consider this to be a forefoot supinatus rather than a fixed forefoot varus. A supinatus has available range to compensate at the metatarsal joint, whereas a forefoot varus does not. If a patient has little to no first MTP joint range available, they will be unable to facilitate the Windlass mechanism for effective forward propulsion. The clinician will need to decide the best way to manage this if it is key to the patient's needs and goals. Note plantar callus patterns, skin creases, or pressure areas. These assessments provide clues to how the foot compensates when weight-bearing. It is the first piece of the clinical analysis jigsaw puzzle. Alignment test. The alignment test is the first of the closed kinetic chain tests and is really a test of clinical observation where the clinician notes how their patient stands. As a checklist, these are the general details worth noting. While patient stands in the frontal plane, front and back, assess foot position in relation to the ground, navicular drift drop, forefoot abduction, heel valgus varus, foot position in relation to the leg, neutral, varus, or valgus, tibial position, varum or valgum, patella position, facing straight forward or rotated towards each other, called patella squinting, pelvis, symmetrical and level, shoulders, symmetrical and level, head position, tilted left or right. Consider how the observed alignment is related to Test 1, foot morphology and motion test. Is the foot compensating due to the foot morphology, or is it compensating due to a more proximal imbalance or malalignment? And how is this related to the patient's chief complaint, pathology, or dysfunction? Is any asymmetry between limbs due to the body compensations for misalignment, or is there a structural asymmetry, such as a leg length discrepancy? It is useful to remember that when we stand, the foot will attempt to become plantar grade and fully weight-bearing. It will need to compensate for morphological misalignment by using whatever joint range is available to ensure all 5 metatarsals are on the ground. Observe your patient in the sagittal plane and note head, which is the ear, shoulder, pelvis, lateral malleoli alignment, pelvic tilt, anterior or posterior, as well as any asymmetry between the left and right sides. At this point, you understand how the body has been glued together, what joint ranges of motion are available, what imbalances are present, and how these are being compensated for on stance. It is important to relate this information back to the patient's chief complaint and the management goals. The windlass mechanism is essential for effective forward propulsion gait. The foot's inability to achieve effective windlass contributes to a multitude of foot and lower limb pathologies. The reasons a foot may not achieve effective windlass activity may be either anatomical or functional. A thorough and detailed understanding of the gait cycle is important for the clinician to see why the patient is unable to move efficiently forward without compensation. Consider what and where are the compensations and how they are impacting the patient. This helps the clinician decide a management plan that assists the patient to move more effectively forward during gait. Jack's test is simple, but the information gained is incredibly valuable. To carry out the test, the patient is standing naturally in their usual base of stance. Have them walk up and down on the spot a few times if they are having trouble relaxing, if their feet are unnaturally far apart. Ask the patient to look straight ahead and not to assist you. Lift the patient's hallux with your thumb or index finger. Ensure you have a good position, as you may need to apply significant pressure. Assess and note the force it takes for you to lift the hallux and see the windlass mechanism activate. The more medially deviated the subtalar joint axis is, the more body weight is positioned under the first metatarsal head, the greater force needed to lift the hallux and therefore engage windlass. Defining the amount of ineffective windlass impacting the patient's pain, injury, or pathology helps the clinician decipher what is going to be most important in their management plan for each individual. Manual supination resistance test. The amount of resistance is determined when the foot is manually supinated by the clinician lifting the arch. The patient stands relaxed in their natural base of gait with eyes looking forward. Have the patient walk up and down on the spot a few times if they are having trouble relaxing or if the base of stance appears to be unnaturally wide. Generally, the base of stance is directly beneath the hips. The force required for the foot to supinate under manual lifting of the midfoot is graded 1 to 5, with grade 1 being no resistance to very low resistance, and grade 5 the clinician is unable to manually supinate the foot. The manual supination resistance test can help estimate the likely position of the subtalar joint axis. With low resistance to manual supination, grade 1 to 2, the subtalar joint axis could be more laterally deviated, where less force is needed to supinate the foot. With a more pronated foot, the harder it is to manually supinate the foot, grade 4 to 5, and the more likely the subtalar joint axis is medially deviated. The test result correlates well to what is expected during the gait cycle. This assists in decision-making around orthotic therapy for an individual patient. Grade 4 or 5 result. Consider creating force medial to the subtalar joint axis. Example, rear varus wedge. If the manual supination resistance test is graded 4 or 5 and the clinical goal is to reduce excessive pronation during the mid-stance period of gait, the orthotic would need to supply enough force medial to the subtalar joint axis to supinate the foot. For a grade 5 result, this may simply not be possible, and the clinician needs to reevaluate how best to provide the desired patient outcome. Shoe modification with the use of medial flares and forefoot rockers may be considered in conjunction with full contact accommodative Formthotics. For a grade 1 result, lateral stabilization and support become a large part of the clinical Formthotics management goal, especially if the symptoms, pathology, or dysfunction are in any degree contributed to by the lateral instability due to very low supination resistance. The manual supination resistance test completes another piece of the clinical analysis puzzle. This test provides the clinician with a wealth of information about what part of the body is controlling foot function and foot stability. The knee bend test can be carried out with the patient performing both a double knee bend as well as a single knee bend test condition. During the double knee bend, the clinician will note whether the knees maintain their position over the toes during the squat or if they fall into valgus, drop together. The body's postural position, lean or rotation, observation of symmetry, maintenance of pelvic alignment parallel with the ground surface, changes in foot position, such as navicular drift and drop, rear foot valgum, as a result of any knee valgum occurring. The test can be done with the patient standing balanced on one foot and dropping into a squat, knee bend, position. Watch how the body maintains its postural control and how it attempts to compensate for imbalance or weakness. Note the ability of the pelvis to be maintained in a level position during the single limb test. Look for a Trendelenburg sign. Relate your clinical observations back to both the patient's pathology and to the other tests they have performed up to this point. This creates the building blocks of information that assist us to understand the clinical picture and make robust, accurate management plans for patients. Neuromotor balance helps to assess how well the body's systems maintain a stable, upright position. Inability for the body to stabilize itself will often lead to compensatory changes to function and gait. Examples could be a widening of the base of gait to increase stability, increased frontal plane posture sway during gait, shortened stride length, increased stance phase time, delayed heel lift, etc. Understanding and identifying if there is a difficulty in balance helps the clinician analyze the gait cycle effectively, as well as assist in the decision-making process for orthotic management. There are 3 test options for the neuromotor balance test. 1 or all 3 tests may be used. The patient stands in their normal base of stance. Get them to walk up and down on the spot a few times if they are finding it difficult to relax or if they put themselves in an unnaturally wide base of stance. Ask them to balance on one foot. Then return to standing naturally and repeat with the other limb in single limb balance and record your findings. Note if they can maintain balance and how they maintain balance. What does the foot do? Stay stable with balance being maintained proximally, or is the foot pronating with the knee going into valgus? What does the pelvis and trunk do? Which direction are they most unstable in? Lastly, repeat the test again with the patient's eyes closed. Remember that patient safety is paramount. There will be some patients who may require you to support them in case they lose their balance completely and begin to fall. In some cases, this test may not be safe to perform. This test is a measure of dynamic balance and stability, which challenges the body to move outside their base of support and depend upon several physiological systems to maximize performance. To perform this test, it is helpful to tape some lines on the floor in an asterisk or Y shape with even spacing between the marked lines. The patient stands in the center of the star with their midfoot in the center. Patients' hands can be placed on their hips, iliac crest, throughout the test. The patient will balance on the stance limb while reaching along the taped line as far as possible with the other foot, lightly touching the floor with the toe of this foot before returning to the starting position. Note, distance reached along the line each time, if the patient's hands come off their hips, if the stance foot moves, they lose balance completely. It is a good idea for the patient to have a couple of practice runs before recording the results and repeat tests can be done. The goal for the patient is to reach as far as they can along the lines of the star. This requires the center of gravity to be maintained. Individuals will find the best way to maximize their reach distance, but generally all anterior reaching is done with the trunk upright and the hip and knee of the stance limb flexed, while posterior reaching is counterbalanced by forward trunk flexion most of the time. The clinician is looking for length of reach, balance maintenance, and limb symmetry. Remember to ensure patient safety. The forefoot stability test provides the clinician with 3 pieces of key information to assist in the decision-making process. This helps decide the role of foot orthoses for patient management and provides an insight into what orthotic modification may be beneficial to the patient. Things to note include 1. The patient's effort or perceived effort to rise on their forefoot, both single and double limb heel raises, tiptoe. 2. Ability to maintain balance while weight-bearing on the forefoot. 3. Whether there is a direction of forefoot balance instability that is relevant in the current clinical picture for this patient. Forefoot balance and forefoot instability are often found in a situation where the instability is notably lateral, in supination, and the patient has a lateral acute or chronic injury or pathology. It is important to try to link the lateral instability back to the foot morphology. For example, where a patient has a forefoot valgus, plantar flexed first ray morphology, they are more likely to be very supinated when they rise on the forefoot, as the foot will have a tendency to fall along the morphological valgus of the forefoot. Should this situation arise, the clinician should be considering the best forefoot Formthotics modifications to improve lateral stability. The clinical jigsaw puzzle now has a morphological picture and a functional ability picture. This now needs to be completed dynamically with thorough gait analysis.